Went to medical school here, residency and fellowship, and she focuses on islet transplantation for diabetes and for pancreatitis.
Thank you. Sorry, Dr. Chinakotla got called into a liver transplant this morning, so I am going to jump in and give his part of the talk for today. So I'm sorry he can't be here, but here he is in spirit. There's a picture of Srinath Chinakotla, and I will have integrated some of his slides with mine, and hopefully we'll give you the overview he would of the TPIAT procedure. So as many of you probably know, here at the University of Minnesota, we have a pretty extensive surgical program for treating chronic pancreatitis, and I'm going to talk about TPIAT specifically in children because that's by far the most common pancreatic surgery we would use for kids. Dr. Kirshner is here to talk later in the adult session, and we'll talk a little bit more broadly about pancreatic surgery for adults with chronic pancreatitis. So when do we start thinking about TPI in children? I'm going to skip giving you any background on chronic pancreatitis because you've already heard about that, but this is obviously a procedure that's very specific for children who have recurrent acute and chronic pancreatitis. So they have to have that underlying diagnosis of pancreatitis, obviously, and it's a big surgery. So this isn't going to be the first thing that we're going to go to in our treatment repertoire. We are going to first treat them medically, and with some of the modalities you heard from Dr. Armfield, and then sometimes if they have stones in their pancreatic duct, they might be candidates for endoscopic therapy. And it's really once we've used those lesser interventions, medical and endoscopic therapy, and they're failing that we're thinking about actually intervening with a more major surgery like TPIAT. And also, this is not a surgery we use for someone who has pretty mild pancreatitis who's functionally doing well. So this is also for children who, in particular with their pancreatitis, are having disability. It is interfering with them attending school because they're ending up in the hospital or the emergency department. They're getting treated recurrently with opioids for really bad acute flares of pain. There are other surgical options. The reason why we typically prefer TPIAT in children, a lot of it boils down to that many of them have genetic disease, as you heard from Dr. Schwarzenberg. And so when we're dealing with a genetic disease that's infecting the entire pancreas, oftentimes the best option is to entirely resect the pancreas. So other procedures that might be considered that you'll hear about later would include duct drainage or other resection procedures, but again, not something that we use very often these days in children. So what are we doing when we do a total pancreatectomy islet autotransplant? I'll show you some better pictures that I have from Dr. Chinakotla, but I really think about this surgery as having two parts. There's the pancreatectomy part. So when we're taking the pancreas out, our goal is to relieve the pain, relieve the disability that was associated with that pain, restore quality of life. And then there's the second part of the procedure, which is the islet autotransplant. And that's the part of the surgery that we focus on trying to reduce the burden of diabetes that would occur by just taking the pancreas out. Because you could do a total pancreatectomy alone. Unfortunately, you'd make none of your own insulin, so you'd be dealing with a more severe form of diabetes, more equivalent to type 1 diabetes or juvenile diabetes, where you need full insulin replacement therapy. So by giving back the islets and infusing them into the patient's liver, we can get some patients off insulin, and even those patients who continue on insulin therapy, we're able to reduce the severity of their diabetes. So these are some schematic pictures of Dr. Chinakotla of what the surgery actually involves. So I always tell people this is really complicated. The pancreas is not anatomically an easy organ to resect. And so when we're doing a total pancreatectomy, it's actually taking out more than just the pancreas. So we're removing the pancreas, we're removing part of the duodenum that wraps around the head of the pancreas, we're putting the GI anatomy, the plumbing back together, taking out the gallbladder if it's still there. And because of the vessels that drain the spleen, we're also removing the spleen. So the anatomy that you're left with at the end is no pancreas and also a little bit of a different continuity of the GI tract. In the islet portion of the procedure, we use the liver as the new home for the islets. So the pancreas is sent to a special laboratory where we do the islet isolation. We have a special team there. Here at the University of Minnesota, they actually have 40 years of experience doing islet isolation, so they're very, very good. Very good at isolating islets from children in particular who are a little bit different from adults. And they send those islets back to the operating room in a medication bag. So they kind of come back like they're a medication or a biologic product. At the very end of the surgical procedure, the surgeon is going to cannulate a tributary of the portal vein with an IV, and those islets just drip in under gravity. So they just follow the blood flow into the liver, and that's how they get in the liver. Because the liver branches into very small vessels, they become stuck there. So they can't pass through the liver. And over a period of a few months, they start to set up a new home in the liver. We call that the engraftment period. And they gradually start to make insulin again. And after 3 to 12 months after surgery, we can get some patients about 40% overall off insulin. So we do this surgery for both children and adults. I actually see both sides of the spectrum. So I also do, because of my research work, a lot of care in the adults who have TPIAT surgery, and a lot of aspects of the surgery is very similar. So I think a lot of what I'll be saying is actually also relevant for adults, although you'll hear more of the adult side of the spectrum later today. But there are some differences that are important in children that we keep in mind with this surgery. So children are not just small adults, and I think as you heard earlier, the cause of disease is a bit different in children. Adults can have genetic disease too, obviously, but in children, that is the predominant cause of disease. So most of our kids, especially as genetic testing is getting better, who have TPIAT actually do have an identifiable genetic cause. Children are still growing. They're still going to get taller. They're going to go through puberty. They're going to school. So they have different things that we need to pay attention to that aren't applicable to adults. Surgically, there are actually some technical challenges in children. So not that this is an easy surgery for anyone, but particularly young children like Malia, who you heard about earlier, they're smaller in size. So the surgery can be physically more challenging. And the isolation actually has some special considerations for our isolation team because the islets can be a bit more embedded, and what we mean by embedded is a bit more wedged into the digestive tissue. We also see kind of a unique spectrum of outcomes in these children. They're particularly these very young children, pre-pubertal, pre-adolescent age children seem to have overall statistically a bit better outcomes. So there seems to be something different about these small children too. So what is our clinical care involved for this? So again, I just want to emphasize that TPIAT is a very major surgery, and it's really reserved for people who are failing medical management because we know that everyone is going to have some lifelong implications of having this surgery. So everyone has insulin needs for at least a while after surgery and a lifelong diabetes risk. Everyone is going to be dependent on pancreatic enzymes for the rest of their life. So there's lifelong exocrine insufficiency involved. And everyone's going to be asplenic. And so we need to take particular precautions about certain bacterial infections. And then there are risks of getting a surgical complication. We do see some patients, even some children, who have persistent pain syndromes that we have to deal with, sometimes because of some of that hyperactivity of the nerves still being present that Dr. Armfield talked about. So it's a really big team. There's a lot of aspects to the surgery. So not only do we need a surgeon, but we need a medical surgery team for this. So it can't just be a surgeon doing this surgery. There's the surgeon, and then there's the medical care surrounding it with gastroenterologists, endocrinologists, the pain team, physical therapists, psychology, dietitians, our nurse coordinators. Some patients may come in with specific causes of disease like cystic fibrosis, where we have to bring in other specialists like pulmonologists to evaluate and assist in their care. And then many of the patients who actually come for this type of specialized surgery are not from the local area. They're going back somewhere else where they're going to have to follow up with a primary care physician. So that person becomes a really important part of the care team. And the patient and the family, super important part of the care team, because as you heard, this is hard work, number one. So that patient and that family have to really participate in the surgery process. It's not a passive surgery. And then not only that, but I think you have to actually be aware of some of the lifelong implications, the lab monitoring that you need. You have to be attentive to symptoms and let providers know so that we can give you the best care possible. So what is our post-operative management very broadly involved? Well, we obviously have some diabetes management initially with this surgery. We are trying to protect the beta cells of the islet, so that's the part of the pancreas that's making insulin so that they can survive as best as possible in the liver. And the way we're doing this is by trying to keep the blood glucoses or the blood sugars very tightly controlled after surgery because we know it helps more of the cells survive. but that can be a real challenge. It does mean having pretty frequent monitoring, having to sometimes deal with low blood sugar or hypoglycemia. Pain control is a big part of the surgery recovery process. You have the old history of pain from the pancreatitis, but also the new surgical pain that we have to deal with for a few months after surgery. We have to consider the nutritional aspects. So early on, that involves actually just considering someone getting enough nutrition to recover from surgery. So all of our patients here have a feeding tube because that way we can get enough nutrition in them past the site where we did surgery so that they don't have to eat and get nauseous and vomit and deal with all of that, but yet they still get enough nutrition that their risk of wound infection is reduced, their risk of having like a hernia or wound complication is reduced, that they are able just to heal better. And then long-term nutrition, we have to think about someone getting appropriate doses of pancreatic enzyme replacement, actually taking that with their meals. That can sometimes be a challenge, sometimes with teenagers in particular, just remembering to take your medication with every mealtime. So we need to make sure people are getting proper pancreatic enzyme therapy. And pretty much everyone after the surgery is going to need a multivitamin. Sometimes, mostly early on, we use a pancreatic specific multivitamin. Sometimes patients will transition to a standard multivitamin later, but we need to be monitoring for fat-soluble vitamins and other deficiencies that can occur after the surgery. And we need to be thinking about the fact that we're removing the spleen. So there are, fortunately, some very good immunizations that are currently available for things like pneumococcus, so a pneumonia bacteria and a meningitis bacteria that can occur when someone doesn't have a spleen. So we vaccinate everyone beforehand. Sometimes people need booster vaccinations later afterwards. And if anyone has a fever, we instruct them to get, right in to be seen so we can make sure that they don't have any infectious complications. So what have we learned from outcomes? So one of the things that we've tried to do here for about the past 12 years is actually really systematically follow everyone up who has surgery. So actually, anyone who's been through surgery here will know that I will approach them with sometimes multiple studies and saying that we're trying to learn about long-term outcomes. And so everyone who comes here is invited to participate in a research study. And fortunately, about 95% of patients will participate in at least our observational study. So we're able to get data for most everyone. And that's what helps us learn about this procedure and advance this procedure. So this is from Dr. Chinnakotla, just looking at kind of acute early surgical complications. And this is a big surgery, so it's not uncommon to have a complication after surgery. About 20% of patients will. And most of the surgeries have to do either with bleeding, infection, or something that's maybe leaking or obstructed where things are put back together either in the bowel or the bile duct. So those are mainly early complications that we're watching for. Everyone who comes in for this surgery basically is using opioids. That hopefully isn't on a chronic daily basis. I think we see less chronic daily opioid use now than we used to years ago. But at least everyone is getting treated with opioids intermittently. And so what we see long-term in children in particular is that there is about 15% of patients who will still be reporting that they're being treated with opioids long-term. So it's not a 100% success. Some of those challenges that we see with chronic pain syndromes weigh in here. But the vast majority of patients, 85% to 90% of patients, are getting off narcotics long-term. We look at, I think even more importantly than narcotic use, how someone functions. So we look at health-related quality of life measures that we can give standardized instruments for. And when we see that, we see a pretty significant clinical improvement in health-related quality of life. We talk about standard deviation scores in medicine and research. So a 1 standard deviation improvement is what we see on average, and actually up to 2 standard deviations improvement in children. And 85% of patients will say that their pain is either resolved or much better compared to before surgery. The challenge is that overall about 15% of patients still have a significant pain burden after surgery. So some of the work that Dr. Armfield's team has been doing with getting patients ready for surgery, the prehab stuff has really been to address that component of residual pain syndrome and try to actually bring that down towards 0. So when we look at the health-related quality of life, so this is from about 1,500 surveys of patients having TPIAT here. And actually, this has both pediatric and adult data, but it's just, just graphically what this shows is 0 is before surgery and then years out after the TPIAT surgery. And children are actually the blue circles and adults the gray squares. I'd say adults come in with a little bit more of a mixed bag in terms of past medical history, comorbidities, all of that kind of stuff. But overall, what we see is a pretty robust improvement from baseline in both groups. It's really important for us to get kids back in school routinely, so not missing any school at all except for routine appointments would be a goal. Getting them back in the sports. Sometimes patients before surgery might not be able to play sports they used to, like soccer or football, because there's a worry about collision. So just getting patients back to those routine activities, and what we see is a really significant change from before surgery to after surgery, a reduction in number of days limited in activity, and patients who are missing any school because of pain symptoms. And then finally, the diabetes part. So our ultimate goal is we'd love to get everyone insulin independent and off insulin after this surgery. We don't see that in everyone. Actually, if you took our all-comers overall, it's about 40% who come off insulin all the way after surgery. But what we do see is in children who are younger, who are about 10 years of age or younger, this likelihood of going off insulin increases. And if you go down to children who are 3 to 7 years of age when they have surgery, about 3 out of every 4 comes off insulin. We don't really know exactly why that is. There are a couple theories behind that. One is that there are, in other populations, autopsy studies that show that young kids have an ability to regenerate their beta cells that is not present in teenage years or adults. So there might actually be some capacity for regenerative growth in the young children. The other thing is that young children actually have very, very low insulin needs. So it might be a really good environment just for that islet engraftment part because you don't have the same demand placed on that islet graft. So as children get older, as teenagers start to have a pretty similar rate of insulin independence to adults, although they do tend to preserve insulin independence longer. And we know that more islets is better. So one of the things we talk about is when is the right time to intervene, and I don't have a perfect answer for that, but when we know someone is headed down the road to TPIAT and that's going to be the eventual endpoint, we start to think about intervening sooner rather than later so that we're not losing islets along the way. And many of you might have heard the term, if you're familiar with TPIAT, islet equivalence, IEQ. So that's just kind of a measure of islet number. It adjusts for the fact that some islets are bigger than other islets, so we have small islets and large islets. So islet equivalent is kind of an islet mass number that we look at. We love it when we get more than 5,000 islet equivalents per kilogram. That's a great number. It is important to know, so sometimes people ask me, well, if I'm on insulin, does that mean my islets aren't working or they've failed? And that's not exactly the case. It's not just a yes or no thing with the insulin independence. If you are on insulin after the surgery, most of the time, those patients actually have some of their cells working for them in the liver and producing some insulin. And our body's ability to regulate blood glucoses by producing insulin is much better than what we're actually able to do by giving insulin injections, because even our fastest acting insulins that are on the market right now take a few minutes to start working, and it takes 4 hours for them to have their whole effect. The way our body produces insulin is pretty much minute by minute. So our body is minute by minute putting out different amounts of insulin into the bloodstream, and that insulin acts for about 10 to 20 minutes and is out of your system. So our body really rapidly adjusts to correct high or low blood sugars, and anytime we can actually have some of our own cells working for us, it makes the glycemic control we can get after surgery smoother, so you don't deal with as much variability. And we think, although we're still trying to get the funding to actually definitively establish this, we think that that should translate into reduced risk of diabetes complications, better quality of life, better long-term outcomes. So many of the kids that we see here have genetic forms of disease, and we've looked very specifically actually at PRSS1 disease because that's the most strong hereditary risk factor. It's considered an autosomal dominant form of hereditary pancreatitis. So oftentimes if one person in the family has PRSS1, multiple people have had pancreatitis. And when we look at duration of disease, we see, unfortunately, that once people come to us as adults, if they're more than 21 years of age or have had disease for more than 18 years, it's almost unheard of for us to get them completely off insulin. Insulin independence is very, very rare in this hereditary condition once we get to adulthood. We're able to use the data on about the 80 patients we have here who have PRSS1 to look specifically at what is the effect of waiting an islet mass. And it's slow, but it's significant over years. And so if we wait 5 years with PRSS1 to do a TPIAT, statistically, we lose about 13% of the islet mass for every 5 years of age, or perhaps more importantly, if we actually look at disease process, about 22% of the islet mass for every 5 years. So waiting, if you're going to go to surgery, then waiting 6 months or a year may not be that big of a deal, but waiting 5 years is probably a significant amount of damage to the pancreas. Optimistically, though, like even the adults we have coming through with this type of disease process, most of these patients are very successfully off opioid therapy. So about 85% are completely off opioids after the surgery with PRSS1 disease. And the few that are on are mostly adults, but in both age groups, pediatric and adults, this tends to be a successful surgery for resolution of pain symptoms. So what does the future hold for TPIAT? So I mentioned our observational studies. So we actually have one study that is a multi-center study now going on called the Post study, where we're looking it's a prospective observational study of TPIAT. We're looking at outcomes across centers, so not just Minnesota, but 12 centers currently who do TPIAT, so most of the centers that do TPIAT in the U.S., because there's very few of these, and we're looking across the country to see what the long-term outcomes are, and particularly, can we kind of firm down recommendations on timing for TPIAT and who is most likely to benefit from TPIAT? I also would like to actually work on this diabetes component. So basically what happens is when we infuse islets, there's an inflammatory process that occurs and lack of oxygen, other stressors that essentially lead to loss of the islets. So we estimate, we don't really know, we estimate for every 2 islets we put in that one of those 2 islets survives the transplant process well in the average person. So it's quite a bit lost. And so we've had to focus some of this research more in the adult population just for FDA regulations and safety, but we have some intervention trials that are going on in the adult population where we're looking at different blockers of some of these adverse factors in the transplant process, see if we can use some therapeutic agents that will actually improve diabetes. And I hope that very soon we'll be working with more of the technology that is on the market for diabetes. So we actually use insulin pumps very readily in the children who have this surgery. We're starting to look a little bit more closely at use of continuous glucose monitors and how accurate are those early after surgery for insulin dosing, et cetera. But what's really going to be coming on the market in the next couple of years is something called closed-loop pump therapy or artificial pancreas therapy. And that's really a system where you would wear an insulin pump external to your body that would kind of act like a pancreas. It would get input from a continuous glucose sensor, and it would do smart dosing of insulin, upregulate or downregulate insulin secretion. We had the opportunity actually to study an experimental model of this in the hospital with adults and saw a very, very good performance of this artificial pancreas technology in our population as the islets are engrafting. Unfortunately, what's on the market now is not quite as sophisticated as what we need to tightly manage this group, but I think in the next few years, using diabetes technology in this group to get better outcomes may be very real. So in conclusion, we reserve TPIAT for disabling and refractory pain in chronic pancreatitis or acute recurrent pancreatitis, and the reason that this is a second-line treatment after medical and endoscopic therapy is because of some of the risks, including lifelong implications for diabetes risk and exocrine insufficiency. It's really, really important that if someone's having this surgery, that it's done in the context of a multidisciplinary team and that there's management both before and after surgery really to get optimal outcomes. But for those who do have severe chronic pancreatitis or acute recurrent pancreatitis and are undergoing this surgery, I do believe TPIAT can really substantially improve quality of life, allow people to come off opioids, and by doing the islets, reduce the burden of diabetes that would otherwise have resulted from just taking the pancreas out alone. And our ultimate goal is really for people to have a normal, healthy life after TPIAT. So thank you. Anyone has any questions? I'll answer those now, and then we'll take a few minutes break after this. Yeah. Diabetic, yeah. I'm going to talk about that actually in the adult session, but yes. Now, all the studies will say something a little bit different because it kind of depends on what population someone is looking at in time. So, we see a few kids who have diabetes and chronic pancreatitis, but probably only about 5% of kids. Once you get up to adults, if you take kind of just a cross-sectional survey, you probably catch about a third of those patients already having diabetes. And if you follow them for a long time, it's probably at least 50% or so who go on to either get diabetes or at the very least kind of borderline diabetes or pre-diabetes. So yeah, the lifelong risk of diabetes is very, very high. Even if you don't have the TPIAT surgery, there's a really good chance someone will eventually end up having diabetes down the road. Yeah. Yeah. Is now diabetic, yeah. Yeah, unfortunately, that's a long-term complication of all the scarring that happens in the pancreas. All right, thank you. I guess we'll take about a 10-minute break.
I just want to thank our pediatric speakers this morning. I thought maybe Dr. Bellin or Dr. Schwarzenberg might want to just address one question I have, which would be that we didn't address yet, weight management prior to surgery and after. So that comes up quite a bit from our families, like why do we ask them to make that weight reduction and what does it mean for the islet cell transplant?
It's a really good point. So Maria is referring to the fact that if someone's coming through for TPIAT surgery in particular, we have a relative contraindication of someone, if you're an adult and you have a BMI in the obesity range, so 30 or above, or you're a child and you are overweight in BMI percentile, that we're going to ask for weight reduction before surgery. And there's a few reasons for that. There's both surgical reasons and diabetes reasons. So we know that being overweight can have some inflammation in the liver where we're putting the islets. We know it increases insulin demand on the islet, so it could mean more metabolic stress and worse diabetes outcomes later. It also has been associated with increased risk of surgical failure, not being able to get the pancreas out, increased risk of wound infection and complications of surgery. So for multiple reasons, we think we are treating our patients much better. We're providing them a better surgery and a better surgical outcome if we can get them in a healthy BMI condition to undergo surgery.
Any other questions for the three speakers? Take a break. Thanks.
You have been disconnected from the meeting.